In this video, we will review the basics of interictal epileptiform discharges. Specifically, we will look at a few of the most important characteristics of focal epileptiform discharges, and then we will briefly review one type of generalized epileptiform discharge. Hopefully, this will provide a basis for some further learning about epileptiform discharges and epilepsy in EEG. It is important to remember a principle that a normal EEG does not rule out epilepsy. In general, if an EEG is done very quickly after a first convulsion, the likelihood of finding interictal epileptiform abnormalities is about 50%. However, if an EEG is done later than that, the likelihood drops. Prolonged EEG recording and several routine EEGs can increase the likelihood of finding epileptiform discharges in patients with epilepsy, but there are some patients who will never have interictal epileptiform abnormalities on interictal EEG. In order to understand why, we can look at a coronal section of a normal brain. For the purpose of illustration, I will place the approximate positions of some scalp electrodes. The likelihood of finding an abnormality on scalp is dependent on two main factors: the area of the cortex involved and the location of the abnormal activity. If there is focal synchronous abnormal neuronal discharges, which would normally generate interictal epileptiform activity, but it involves only a small area, as demonstrated by this red star, then this may not be seen by the overlying scalp EEG recording, whereas a larger area of cortex involved might be easily seen on scalp EEG. Studies that have looked at the correlation between scalp and intracranial EEG recording have shown that 10 to 20 square centimeters of cortex must be involved in order to consistently see interictal epileptiform abnormalities on scalp EEG. This means that a fairly large area of brain has to be involved in order for us to see it. The second consideration is the location of the abnormality. I have indicated an abnormality in a superficial aspect of the right frontal lobe, very close to overlying scalp EEG electrodes. You can imagine that abnormal electrical activity in the cingulate gyrus, in the mesial temporal structures, or in the insula might not generate the same sorts of potentials on the scalp. I have chosen this study to look very carefully at the characteristics of an epileptiform discharge. To review briefly, this is an anterior-posterior bipolar montage, except in this case we have some additional electrodes. Starting from the top, we have a left inferior temporal chain, then the regular left temporal chain, then a left parasagittal chain, then midline, then right parasagittal, then right temporal, and then right inferior temporal. I have moved the most prominent abnormality towards the center of the page, and you can see it here in the left temporal and inferior temporal region. This is a focal left temporal sharp wave. We will go through a few of the characteristics of a focal epileptiform discharge. In general, the same rules apply when you are looking at any focal epileptiform discharge. First, I will decrease the sensitivity so we can get a better sense of this discharge. Remember that now I have the sensitivity at 30 microvolts per millimeter, which gives us the false impression that this is a low voltage discharge, when in fact it is very high voltage. The first characteristic of a focal epileptiform discharge is that it is sharply contoured. In general, this means that it must be less than 200 milliseconds in duration. There is an arbitrary distinction between sharp waves and spikes, in that sharp waves are less than 200 milliseconds, while spikes are even sharper and less than 70 milliseconds in duration. Although this distinction is made, and we often categorize discharges in this way, from a practical perspective, there does not seem to be any difference in the biological significance of a spike versus a sharp wave. The second characteristic is that this discharge has multiple phases. If we look very carefully at this discharge, focusing on one of the channels, we can see that there's actually an initial positive phase, then the largest negative phase, then a third positive phase, so that we would call this a three-phase or triphasic discharge. However, it is important to distinguish this from triphasic waves, which have a different clinical significance. This discharge should interrupt the background. In other words, it should not simply look like a continuation of normal background activity. we can see that this discharge clearly stands out from the background, and there is a disruption in the background before and after the sharpest component of this discharge. In general, there should be an aftercoming slow wave after epileptiform discharges. Again, we can see this here, here, and here. Finally, there should be a field that makes sense. We have reviewed polarity rules in a different recording, but you can see that there is a downward deflection at P1, F9, a relatively flat recording at F9, T9, and an upward deflection at T9, P9. This would suggest that the maximal negativity is at F9, T9. Similarly, in the regular temporal chain, we see a downward deflection at FP1, F7, and an upward deflection at F7, T7, suggesting that this is electronegative at F7. Therefore, we would say that this is a sharp wave, or sharp and slow wave complex, with maximal negativity at F9, F7, and T9. When we switch to an average reference montage, our suspicion that this was maximal electronegativity at F7, F9, and T9 is confirmed. When we focus on the entire page, we actually see that we have a similar abnormality on the right side, although it is not quite as high voltage. Here we can see a maximal electronegativity at F10, T10, and to a lesser extent F8 and T8. This is also sharply contoured, also has multiple phases, also interrupts the background, is also associated with an aftercoming slow wave, and also has a field that makes sense. This is a right anterior temporal sharp wave. Therefore, on this single page, we have independent bitemporal anterior temporal sharp waves. I have chosen a recording from a different patient to show you a slightly different focal epileptiform discharge. This discharge follows all of the rules we have established for focal epileptiform discharges. It is sharply contoured. There are multiple phases. There is a disruption of the background rhythm. There is a large aftercoming slow wave, perhaps best seen in the posterior temporal region, and there is a field that makes sense. Let us carefully go through the field, as this discharge looks slightly different than the others on anterior-posterior bipolar montage. I will decrease the sensitivity, and if we look carefully, we can see that there is a large downward deflection at P4O2 and C4P4. This would suggest that this is either electropositive at P4 and C4, or alternatively electronegative at O2. Considering most epileptiform discharges are electronegative in nature, this is most likely electronegative at O2. If we look in the temporal chain, we see that there is a downward deflection at T8P8 and an upward deflection at P8O2. This would suggest that there is also a negativity at P8. Therefore, this discharge is maximal in the posterior temporal and occipital region. When we switch to an average reference montage, we indeed see that this discharge has a maximal electronegativity at P8 and O2. This discharge also has a very nice example of a classic high voltage aftercoming slow wave. This is an example of a very different type of epileptiform abnormality. Note that the sensitivity on this study has been decreased dramatically to 50 microvolts per millimeter. For the sake of perspective, I will increase the sensitivity up to the usual 7 or 10 microvolts per millimeter. And you can see how high voltage these abnormalities are. Decreasing the sensitivity back down allows us to look more carefully at these discharges. On first blush, you can see that the discharges appear to involve most of the head, and therefore we would call this a run of generalized epileptiform discharges. All of the same rules that we saw with focal epileptiform discharges apply, however. If we zoom in on the left central region, we can see that these discharges are sharply contoured. There is clearly a disruption of the background. There are multiple phases. There are large high voltage aftercoming slow waves. And as said before, there is a field that makes sense, although in this case the field is very diffuse. With this set of discharges, we can see that the changes in phase, and therefore the maximum negativity, are at C3, CZ, and C4, with some involvement of the frontal head regions as well. Therefore, we would say that these are maximal in the bilateral frontal central regions. You can see that these discharges come in runs. Initially, for the first second, the frequency is approximately 3.5 hertz or so. Gradually, as we move towards the end of the page, the frequency decreases slightly to between 2.5 and 3 hertz. These are 3 hertz generalized spike wave discharges, which are seen most commonly in childhood absence epilepsy, but can be seen in other types of seizure disorders as well. If we scroll forward slowly, we can see that this run of discharges continues for a long time before a gradual offset. Considering the duration of this run of discharges, which is approximately 15 seconds, we would expect that there would be some subtle alteration in level of consciousness. One of the major distinguishing factors between focal and generalized epileptiform discharges is that runs of generalized epileptiform discharges constitute the EEG correlate of clinical seizures. The significance of focal epileptiform discharges and how they connect to seizures is less clearly understood. In this video, we have reviewed the basic concepts of both focal and generalized epileptiform discharges. Obviously, the characteristics and biology of these discharges is far more complicated than has been demonstrated here, but hopefully this provides a basis for further learning.